Okay. All right. Unless someone interrupts me, I'm just going to assume you can see my screen. Um, so Austin and Lunch Club, thank you for having me. I'm Jansen, MS4, so I'll be applying to the cycle. For Match, I'm applying to family medicine, and I chose this topic about Ozempic because it's kind of like a cliche drug right now, and that happens. Something we need to be aware of as clinicians in the future is medical trends, things people are doing, maybe with or without doctor guidance, or things that people think are healthy or not healthy, etc. We need to be aware of those, and we need to counsel our patients accordingly. And so prior to my family medicine rotation in July, I did an elective with Dr. Jayesh Patel at Southern Primary. He was fantastic. I learned a lot. I had the perception that Ozempic was just for weight loss. It was people trying to get the easy route out. I didn't really think it was an effective diabetic medication. I thought it was kind of people, quote unquote, cheating the system. But then, however, I had some friends on it. I know some people personally who are on it, and I also saw the clinical setting, and my mind was completely switched. I now think it's a fantastic medication. I think a lot more people should be on it if indicated, and I wish insurances would cover it better. And then, so my mind was kind of just changed on this medication in particular. The news and everything was kind of misleading. But then when I saw it in a clinical practice, I became a fan. And there's a lot of really awesome indications, which I'll go through. So Ozempic. So here's just a little clinical situation. So 45-year-old female presents with a blood pressure of 132/81. So not bad. Respiratory rate of 15, heart rate of 74. Today is her annual wellness exam. She's up to date with all screening exams, so nothing to worry about in that regard. Past medical history is positive for obesity, hypertension, and diabetes. So of those things, it's telling you she's still obese. It doesn't give you a BMI or a weight. So we're just going to go with, obese. Hypertension, which on presentation seems to be controlled, in diabetes. Her most recent A1C is 7.4, up from 7.1. So we see a negative trend in that regard 3 months ago. She expressed she would like to lose some weight to help with her chronic knee pain. She is compliant with her current medication regimen of amlodipine 10 milligrams and metformin 1,000 ER once a day. What is the appropriate medication adjustment for this patient? So I said adjustment because it could be taking off or adding, or maybe you need to keep it the same. So kind of taking each one of those things. She has no new presentations. Chronic knee pain, and maybe you do pain control, but that's not really the direction I'm going with this. Amlodipine seems to be controlling her blood pressure. Metformin ER is no longer controlling her medication. She is compliant, and she would also like to lose weight for other things. But as we know, as clinicians, losing weight can also assist in diabetic and hypertension management. So there's a lot of reasons that we would want to encourage this patient to potentially lose some weight. Again, I didn't give a BMI. Maybe I could have for a better clinical vignette, but I digress. So what is appropriate medication adjustment for this patient? Well, this entire talk is about Ozempic, so you can probably assume that I'm going to suggest she be added on Ozempic. And there we go. So what is Ozempic? Ozempic is a diabetic medication, and it's in the class of semaglutide, which works to target the pancreas, the liver, and the stomach. And it's efficacious because it does have 3 targets. The pancreas to produce more natural insulin, which is good because then you don't have to put the patient on insulin. The liver from making sugar, which is one of the ways that it assists in blood loss or weight loss. Also, that decrease your sugar, your blood sugar, which is going to decrease your A1C and decrease the progression of your diabetes. It also works on the stomach to decrease transit time, which is one of the main effects of weight loss in Ozempic, which I'll get more into, but it creates, it causes weight loss because people feel satiated. And so one of the things you have to do when counseling your patient is tell them not to eat until you're hungry. because it's going to naturally make you the easiest way to explain it is a caloric deficit, which over time will result in weight loss. So the kind of textbook mechanism is semaglutide improves the efficacy of incretin function by activating GLP-1 receptors. So GLP-1R is the class. It acts by numerous mechanisms like augmented insulin secretion from the pancreas, which is glucose dependent, inhibition of glucagon releasing and suppress hepatic, so that's the liver function, gluconeogenesis, thereby reducing both fasting as well as postprandial glucose. So who should take it? And this is where you kind of start to get where you maybe hear things from the media, or you kind of hear, some negative connotations in regards to this. So patients with hemoglobin A1Cs in the diabetic range. I will say semaglutide is not a first-line medication. The first thing is always diet and lifestyle. If you can control any condition, hypertension, blood pressure, et cetera, by diet and lifestyle, that's the way to go. Least invasive and cheapest, scaled upwards to most invasive and most expensive, and everything's a continuum. And that's how you should think about every patient in every situation, especially diabetes, something that lifestyle modification has a huge impact. And we could get into a number of reasons why patients might not be able to comply with that or whatever, but that's kind of beyond the scope of this discussion. So first line is typically metformin. There's a few contraindications to that, but in general, most of your diabetic patients are going to be on metformin. The second line medication, new research and new studies are showing, are GLP-1s. It is very effective. It has a lot less risks than some of the other medications. So we are thinking this should be the new avenue of diabetic management with two medications. Semaglutide's next. Ozempic is just one of the most common of that class. Type 2 diabetics, patients who have a health benefit from losing weight or desire to lose weight. And then I did want to caveat, it is not FDA approved for weight loss. There are ones, Wegovy, for example, is approved for weight loss. That's another in this class. I think the FDA is moving in that direction. However, as we all know, there are many medications that we use that their primary research is not what they found to actually happen. Gabapentin is a great example of this. Gabapentin was not designed to be a nerve pain medication, but most people are on gabapentin for that reason. It's an off-label use that's very effective. Ozempic kind of has the same concept. It doesn't mean it's unsafe. So when you hear FDA has not approved it for weight loss, that doesn't mean we can't use the quote unquote side effects. Same thing when, sexual dysfunction, we can use antidepressants to decrease sexual drive if someone is hypersexual. So we know as clinicians that we can do these things, and these are things to be aware of. The patient in the vignette expressed the interest in weight loss to help her knee pain. We know one of the reasons for chronic osteoarthritis is obesity. And then also it is an injectable, so it's not just an oral pill. You have to be able to properly administer the medication. So someone who either doesn't have home health, if they're unable to administer that themselves, for some reason has the mental capacity to not be able to, or something, they wouldn't be a candidate, obviously. Who should not take it? There are some absolute contraindications in clinical trials in mice. There was found to increase thyroid cancer, medullary thyroid cancer. So if you have a personal family history of that, MEN2 as well, because we know there's a thyroid component to that. And then it wasn't studied in pregnant women or women trying to conceive. Very hard to get clinical trials approved to do that in humans. So at this time, there's not enough post-market data to support the use of in that population. So we actually, however, the thyroid components of it, the cancer and everything, the studies that have been done have only been done in mice. There's been no indication that this has actually happened in human trials because it's not been allowed. So they found that in mice, it increased it. And however, the parafollicular cells that we know that are increased in medullary thyroid cancer, Mice have like tenfold the amount of those at baseline than we do. So it's not necessarily the best specimen. Maybe like a monkey or something would be a better specimen to determine that. But at this time, that's the contraindication. So we're going to abide by that. We don't want to risk anyone increasing parafollicular cells that can, of course, then become, cancerous. I hope that makes sense. Does that make sense to everybody? Okay. Yeah. Thanks, Nina. So some side effects to watch for. Hypoglycemia. Obviously, any diabetic medication that's controlling blood sugar, its goal is to decrease blood sugar. But then if they were to fast or they were to have a low blood sugar, like a diet, low glycemic index meal, beyond kind of what's standard for them, they might go hypoglycemic. This is less common than like glipizide, for example. Glipizide is used to be a second-line medication behind metformin. It's kind of getting down because its biggest downfall is hypoglycemia. The biggest population of people who are diabetic is elderly. What do we not want someone who's old to do is fall for a number of reasons, orthopedic reasons, neurological reasons, whatever. How do you prevent falls? Control their blood sugar, control their blood pressure. Two big reasons. This is a side effect of all medications, all blood sugar medications. Diabetic retinopathy or vision changes, there was there was more of this side effect than other placebo-controlled studies or double-blind trials compared to other diabetic medications. Pancreatitis, the mechanism is not yet known exactly, but it acts on the pancreas, and we know the pancreas is very sensitive. So assuming something to do with that, but the exact mechanism is not yet known. Diarrhea or nausea, obviously that's uncomfortable. No one has ever died from diarrhea or nausea. They may not like it, but people do, if they end up throwing up, have stomach problems. Diarrhea, and then I guess vomiting, emesis, I think is the correct word, that can cause kidney damage because of dehydration. So it's kind of like it's not a direct kidney damage, nephrotoxic, it's a byproduct of the side effects. And then also it's not an absolute contraindication, but it's a relative contraindication for people with cholecystitis, choledocholithiasis, any gallstones, whatever. Again, all of the diarrhea and nausea and the gallbladder problems primarily have to do with the slowing of the transit time of digestion, which is one of the, again, the mechanism of why it makes you lose weight. You have to also pay attention to, if you're slowing down natural digestion, what's it doing to the bile and everything like that. So those things make sense when you think about it mechanistically, but sometimes I think we forget about those types of things. Let me move you guys down here. So these are all of these charts I took from the Ozempic website. I wish I knew how to make charts like this, but I don't. So obviously this data is presented in a fashion to make us want to prescribe Ozempic. This is from their website. Of course it supports it. So I do want to caveat that. However, these are only medications compared in the same class. So there's 4 of them in this class, Ozempic, Verse, and then there's 3 medications, or 4, sorry. These are only semaglutides. I'm not comparing Ozempic to metformin or whatever. So, and just time to explain, all of the parts of the study